My name is Rishi Desai. I'm an instructor in medicine at the Harvard Medical School and the Brigham and Women's Hospital in Boston. In this video, I'm describing the results from our study that looked at the association between TNF-alpha inhibitor use and the risk of incident hypertension in patients with rheumatoid arthritis. This work was conducted in collaboration with several other colleagues at the Harvard Medical School and the Harvard School of Public Health. Patients with rheumatoid arthritis have high incidence of cardiovascular comorbid conditions. One of the most common conditions observed in these patients is hypertension, which is seen in nearly 30 to 40% of the cases. TNF alpha or tumor necrosis factor alpha, which is a pro inflammatory cytokine implicated in the pathogenesis of rheumatoid arthritis, is also present in high abundance in patients with high blood pressure. So, we hypothesize that reducing levels of TNF alpha through TNF alpha inhibitor use in rheumatoid arthritis patients may also be associated with reduced risk of incident hypertension. We tested this hypothesis using data from two large employer based insurance programs within the US. We designed this study using an active comparator sequential cohort setup. Accordingly, we identified observational cohorts of TNF inhibitor or non biologic DMARD initiators using 1 month enrollment periods. After enrollment, their exposure to respective treatments was measured in a monthly time varying manner. Note that this design attempts to emulate a randomized controlled trial, and when paired with appropriate statistical methods, it can give unbiased estimates of treatment effects. It can also be conceptualized as matching the two treatment groups on calendar time of treatment initiation. We measured several time fixed and time varying covariates in this study. As shown in this table, the distribution of time fixed covariates at baseline, at 6 months, and at 12 months post index period was similar between the two treatment groups. However, the distribution of time varying covariates, including NSAID use and oral steroid use, was noticeably different between the two treatment groups at baseline, at 6 months, and at 12 months post index period, essentially justifying their inclusion in the study as time varying covariates. The comparative effect of TNF inhibitor use on the risk of incident hypertension was estimated using inverse probability of treatment weighting in a marginal structural model that accounted for both time fixed and time varying confounders. After full adjustment for all the confounding factors that we measured, we did not find any difference in the risk of hypertension between TNF inhibitor use and non biologic DMARD use. We also evaluated the association between duration of TNF inhibitor use and the risk of incident hypertension using a dose response marginal structural model. The IPTW adjusted difference in the absolute risk of hypertension between the two treatment groups at 36 months was 1.5% with 95% confidence interval including the null, again indicating no association between use of TNF inhibitors and the risk of incident hypertension. So, in summary, we did not find an association between TNF alpha inhibitor use and the risk of hypertension in patients with rheumatoid arthritis. Our results indicate that the overall cardiovascular risk reduction conferred by TNF alpha inhibitors in rheumatoid arthritis may be mediated through their beneficial effects on systemic inflammation or their beneficial effects on cardiovascular risk factors other than hypertension, for example, diabetes. Future research identifying the mechanism for reduced cardiovascular risk after TNF alpha inhibitor treatment in rheumatoid arthritis may be helpful in targeting specific subgroups of patients to maximize the beneficial effects of TNF alpha inhibitors on cardiovascular endpoints.